Hello, my name is Jeff Bohr. I'm here with my colleague, Dr. Akshay Desai, and we're going to discuss two cases of patients with heart failure to determine how we might take care of them. The first case involves a 67-year-old Caucasian man. He suffered a myocardial infarction 4 years ago. Heart failure was diagnosed 2 years ago, and he was hospitalized 2 months ago for worsening symptoms. He's stable now, but is limited by dyspnea when he walks 2 blocks. Currently, on physical examination, his heart rate is 80 beats per minute and his blood pressure is 120/80. The ECG shows normal conduction, and he's in sinus rhythm. His left ventricular ejection fraction is 28%. His creatinine clearance is 27 milliliters per minute. Since his hospital discharge, his medications have been enalapril 10 milligrams twice a day, furosemide 40 milligrams daily, spironolactone 25 milligrams daily, and carvedilol 25 milligrams twice daily. So this case raises several issues. Akshay, what are your primary concerns here?
Well, I think that this is a patient who has an ischemic cardiomyopathy who has recently been hospitalized. And we know that patients who are recently hospitalized are at high risk for adverse events. And he also remains functionally limited somewhat. Being short of breath on 2 blocks walking is obviously more than we would want for most of our patients, and would put him firmly in the sort of class 2 to 3 range. I think if in that context, I think one would really like to make sure that we've optimized his medical therapy to attenuate his further risk. And I think in that regard, some of the features that are of concern are the symptoms and the persistently high heart rate on exam.
So what would you do to modify his therapy?
So I think that the first assessment in the clinic is really about congestion, since one of the features that might be contributing to his functional limitation is shortness of breath might be residual volume overload or congestion. We know he had it a couple of months ago when he was in the hospital. The exam doesn't suggest that there's a lot of residual congestion. We don't see jugular venous distension or evidence of pulmonary edema or peripheral edema. So in the absence of congestion, the functional limitation may be a limitation of cardiac reserve. He's on a good medical regimen, including a robust evidence-based dose of carvedilol at 25 milligrams twice a day, and dose of an ACE inhibitor, and an optimal dose of diuretics, it would seem, as well as an aldosterone antagonist. But yet the heart rate remains 80 beats a minute, and I think we're well aware now that heart rate itself is a predictor of outcomes in patients in sinus rhythm in this population. And so if his beta blocker dose could be advanced, that would be one option. And unfortunately, I think at 25 milligrams twice a day, that's about as high a dose as we would typically use for someone of an average size. So there isn't really a lot of room for additional beta blockade. I think we've historically considered drugs like digoxin, which have some effect on resting heart rate, but those drugs have become now largely second or third line therapy for most of our heart failure patients and have a narrow therapeutic window. But I think that would be a consideration. Another is the use of Iberdeen, which is a newer drug that's available for heart rate reduction in patients with who are in sinus rhythm with symptomatic heart failure and ejection fraction less than 35%. And I think this patient fits in that bandwidth, and one consideration would be the addition of Iberdeen to slow the heart rate below 70 beats a minute in this patient who's already treated with a maximal dose of beta blockers.
That's the way I would look at it as well. A question, if we attempted Iberdeen therapy, and there are other options, of course, but if we attempted Iberdeen addition, how you mentioned getting his heart rate down below 70, which is fine. Is that your target? I
think so. And you know, what I've understood of the data from the SHIFT trial, which is the large randomized controlled trial of Iberdeen in patients with reduced ejection fraction, is that the benefit of heart rate reduction is seen down to heart rates in the 50s with the composite of Iberdeen and beta blocker. I think that the eligibility for that trial were patients with a heart rate more than 70. So I think precisely how low to go is a little bit of a topic of some debate, and some patients may not tolerate excessive heart rate reduction. But I think that somewhere in that 50 to 70 range is probably the sweet spot for where we'd like to be.
Yeah, the SHIFT actually, as you said, SHIFT found that the best outcomes were in people who were 50 to 60, and that with each increment above that, the outcomes were less good. So if it were me, I would try to get the heart rate down as low as I reasonably could. It depends on whether it would go down or the patient would tolerate it, obviously. But many patients do. I think that the real concern there, and that I hear all the time, and I'm sure you do too, is, hey, wait a minute, you're slowing the heart rate.
Mm-hmm.
And doesn't that reduce the cardiac output? And your goal is to maintain or increase the cardiac output? How about that?
Right, so I think that that's an obvious concern. I think one of the advantages to Iberdeen is that it is a selective inhibitor of the sinus node funny current, so it slows heart rate without any effect on contractility. So as opposed to other agents that we have that slow heart rate and simultaneously have negative inotropic effects that may compromise functional capacity, here it's a selective heart rate reduction. The other is that most of the patients that we are talking about don't have a completely heart rate dependent cardiac output and have some contractile reserve, and so are able to augment stroke volume despite the heart rate reduction to maintain cardiac output. And so I think that there probably is there are a large number of these patients, with particularly in the class 2 to 3 range, who can tolerate the drug and the heart rate reduction without a compromise on functional capacity or outcomes.
Yeah, I think that's right too. I think, though, that beyond that, the data from SHIFT and data that were developed before SHIFT suggest that in people who have systolic heart failure, who have diseased myocardium, reducing the heart rate actually improves myocardial function, improves contractility. And so the cardiac output is well maintained despite the lowering heart rate, which wouldn't be true in a normal subject. It was studies in normal subjects that taught us about the relationship between stroke volume and heart rate and output. This is not a normal subject we're talking about here. And in this situation, the echocardiographic substudy of SHIFT showed that with reduction in heart rate, the ejection fraction improved and this end-systolic volume decreased, which was not true in patients on placebo. But even more than that, more than 20 years ago, Michael Böhm did a study in which he obtained papillary muscle strips from transplant donors and transplant recipients, functional class 4 transplant recipients at the University of Cologne in Germany, and he put the muscle strips on strain gauges and measured contractile force with electrical stimulation, and found that in the normal muscle strips, as he increased the stimulation rate, the contractile force increased and eventually reached a plateau but never came down. In the strips from patients with functional class 4 systolic heart failure, the transplant recipients, as soon as the stimulation began, the force of contractility dropped and continued to drop until he stopped the stimulation, went back to the initial stimulation rate, and the force of contractility increased again. So, I think there's a lot of information suggesting that the concept that reducing the heart rate is going to compromise the cardiac output really isn't relevant for patients with heart failure. Again, it was that set of concepts developed were developed in normal subjects and normal experimental animals, not in the setting of diseased myocardium. So I agree. I don't think that I wouldn't be particularly concerned about reducing the heart rate, but of course one always has to keep a close look and make sure that you're not creating a problem. So. Is there anything else we need to think about with this patient? Is there any other option that we might think about using here?
Well, I think the other thing to consider is the use of novel vasodilator agents, and there is ample data from the Paradigm study that patients who are ACE inhibitor treated who remain New York Heart Association class 2 or 3, who have a reduced ejection fraction, would benefit from a transition to the composite of sacubitril and valsartan. And I think that data is very compelling, with a 20% reduction in cardiovascular death or heart failure hospitalization in patients just like this, who then make the transition to the novel vasodilator combination of an angiotensin receptor neprilysin inhibitor. And so I think that that would be another consideration here, and this patient has a blood pressure that would suggest that they would have been eligible for enrollment in Paradigm and meet a lot of the one consideration is the reduced EGFR, which is a bit below, just below the threshold of eligibility for that particular trial. And so I think if one elected to utilize that agent, one would need to be mindful of the risk for worsening renal function. But I think that's another target for improving outcomes in patients just like this one.
Yeah, of course there are no data at all, so this is total speculation. But would there be any particular reason not to treat first with one and then with the other, as long as the labeled use criteria continue to be met?
First with
with sacubitril valsartan, or first with Iberdeen and then with the other.
Right. Yeah. So I think I think, as you say, no data to tell us which is there. I think the one thing that some have pointed to in the community is that the benefits of Iberdeen in the SHIFT trial were seen on the composite of cardiovascular death and heart failure hospitalization, but were heavily driven by the impact on heart failure hospitalization. The benefits of sacubitril valsartan over enalapril, which was the comparator in Paradigm, on the same endpoint were driven by comparable effects on both death and heart failure hospitalization. And when one looks at death alone, both related to cardiovascular causes or segregated according to sudden death and heart failure death, or even looking at all-cause mortality, there's an impact of sacubitril valsartan in the population. So I think in terms of more bang for the buck, it might be that if this patient could tolerate sacubitril valsartan, that might be a reasonable place to start for that variation. But I think there isn't a lot of data.
It might well be. There aren't many data, but there's one point. This man had a heart rate of 80.
Yeah.
And in Europe, Iberdeen is labeled for reducing mortality in patients with heart failure whose heart rate is over 75 beats per minute in sinus rhythm. And that's what the data show. It was a post hoc analysis that the EMA chose to do. And the reduction in mortality was about 16%, so it was not a trivial reduction. Nonetheless, even though one might point to those data and one might do this, I think you're right. It'd be perfectly reasonable to start on sacubitril valsartan and see how the patient does, and then add Iberdeen perhaps afterwards, knowing that we have no experience in giving this combination.
It's amazing, though, isn't it, how that a regimen that we've considered to be standard of care and inviolable for so long, the trifecta of an ACE inhibitor, a beta blocker, and an aldosterone antagonist at goal-directed doses, now in a short frame, may now look very different with maybe perhaps a fourth drug in the regimen, or maybe a substitution of one for a combination.
I think that latter point is an important one, because we're talking about a case here in which the patient was treated with enalapril. If sacubitril valsartan were to be used, the enalapril would have to be stopped.
Yes.
And the starting dose of sacubitril valsartan would be lower than it would have been in a trial for patients naive to ACE inhibitor, because the patients who have had low-dose ACE inhibitor, this man didn't have low dose, had standard dose, but those patients were more likely to have problems when sacubitril valsartan was added.
This is a case we've called back in the hospital again. It's a familiar problem. This is a 65-year-old woman who has a long-standing history of dilated cardiomyopathy. Her ejection fraction was last measured about 25%. And we think her cardiomyopathy was related to prior treatment with doxorubicin for breast cancer. She was admitted with an acute heart failure exacerbation that happened shortly after she went on holiday. And this happens to be the second time she's been admitted for decompensation of her heart failure within a 3-month interval. So during the course of that hospitalization, she's treated with intravenous diuretics, as most of us would, and her symptoms get better. And this is where the case begins. I'll tell you a little bit about her beyond what I just gave you. That is, in addition to the dilated cardiomyopathy and the breast cancer, she has subsequently undergone, for primary prevention of sudden death, an implantation of a defibrillator. She has some osteoarthritis and depression for which she is treated, has a remote history of hypertension and stage 3 chronic kidney disease. Her current medications, like your patient, include carvedilol 25 milligrams twice daily, lisinopril 20 milligrams daily, spironolactone 25 milligrams daily, furosemide 80 milligrams twice daily, sertraline 100 milligrams daily. I think probably relevant in this case, her social history. She is a widow and lives alone. She has no children. She does drink alcohol on occasion, but has never smoked. And an echo done during the hospitalization confirms the low ejection fraction at 25% with global hypokinesis and moderate mitral regurgitation. And she's in sinus rhythm with a right bundle branch block and a cure restoration of 130 milliseconds. So with that in mind, she is examined on the day that is planned for discharge, and her blood pressure is 120/80. Her pulse is 65 beats per minute and regular. Her jugular venous pressure is 14 centimeters of water, so elevated above the clavicle. Her lungs are clear. Her cardiac exam is most notable for a soft gallop and a murmur of mitral regurgitation. She has a soft belly and a slightly enlarged liver with some pedal edema. So I think we've talked a lot about medical therapy of heart failure, and some of those same issues are probably relevant for this patient. But I guess what I was thinking that we might use this case to talk a little bit about is, how do you decide when your heart failure patient's ready to go home from the hospital? And then we could follow from there. So when you're seeing these patients in the hospital, what are your goals of treatment, and how do you decide when you're done?
Well, one goal would be for the patient to be as close to euvolemic as I could get them. And in this case, the patient has some evidence that she is not euvolemic, that she remains volume overloaded, and probably, I think, needs further diuresis before we add anything else. I say that primarily because her neck veins were abnormal, which is about as hard a piece of evidence of volume overload as I can imagine. It'd be nice to know some weights, but we don't have those to talk about here. So I would probably be thinking about further diuresis and then perhaps adding something else. I think we have to think about adding something else because she's been admitted to the hospital several times in the last couple of months. A couple of things probably should be discarded right away. There are some teasers in that case. Cure restoration of 130 milliseconds, which is higher than normal. But it was associated with right bundle branch block, and the application of CRT, which is the first thing you'd want to think about if somebody has a supernormal cure restoration, has been most effective in the setting of left bundle branch block, not right bundle branch block. That's number one. Number two, even if we were willing to ignore that fact for a moment, Echo CRT, which was published just a couple of years ago, demonstrated two things. First of all, that there was actually a detriment to using echocardiographic criteria for dysynchrony in patients with normal QRS, and a higher mortality rate if CRT was used in that situation. But it also demonstrated that the same was true for people whose cure restoration was between 120 and 130 milliseconds, and this lady is right at the upper limit of that interval. So I would say the first thing I would do would be to dispense with any consideration of CRT.
Right.
I certainly would want to diurese her further. Her heart rate is reasonably well controlled. The question of the impact of her mitral regurgitation should come up, and I think we need further evaluation of that. There's certainly no evidence of life-prolonging benefit from operating on patients with functional MR, which is what this lady has, ischemic MR. But the fact is that with current catheter-based techniques, we might want a more precise evaluation of her mitral regurgitation to see if one of those techniques might be advisable. And then ultimately, if she was further volume unloaded, one might think about using sacubitril valsartan in this situation instead of the lisinopril, I would think.
So let me ask you that the CRT points are well taken, and I think exactly as you say, there's no role in this type of patient based on the data we have. You mentioned about augmentation of medical therapy after decongestion, and then talked a little bit about sacubitril valsartan. So I guess more generally, when you're thinking about instituting chronic medical therapy, are you doing it in your patients before they leave the hospital? Are you waiting for that post-discharge visit?
Yeah.
And then I'll ask you a follow-on to that.
Yeah, that's a very difficult problem, as you well know. If you wait until after hospital discharge, which often is necessary if you want to be sure that the patient is stable, which is when new medications are supposed to be begun, you may have lost the window of opportunity. The patient may not come back. The patient may not be available for the appropriate follow-up after a new medication, et cetera, and you don't know whether the new medication is tolerable at all. So there's a great impetus to begin a new medication in the hospital while you can keep an eye on the patient. I must say that's what I would prefer to do, is to start in hospital where the patient is still under observation. But there are issues that mitigate the possibility of doing that. The tremendous pressure to get people out because of the cost of in-hospital care, et cetera, et cetera, et cetera. So while I'd prefer to start in hospital, I might be forced to start outside of hospital, which means that the patient has to be seen in a hurry. You may lose some patients that way, both because they don't come back and because something terrible happens to them. But I think that points to one of the very important things that needs to be done, which is to make a major effort for follow-up and to provide the patient with some tools for self-assessment after hospitalization, so that if things are trending in the wrong direction, you may hear about it. What do you think about that?
I think all these are critically important points, and I agree with you on the point about starting medications as you can before going home. There is this tension between the pressures that we have fiscally on length of stay and the things we'd like to do to keep our patients well over the long term, and it's created this interesting dichotomy in national studies between an inverse relationship that some have reported between length of stay and readmission rates nationally. But I think that you're right, that prior to discharge there's work to be done beyond medical therapy, and one is getting patients to commit to a time to follow up at an early post-discharge interval. And I think I've been impressed by some of the data from a number of the studies of heart failure disease management, but one in particular from Todd Colling at University of Michigan that really looks at the value of just an hour of nurse-based education prior to the patient leaving the hospital. And at least one single-center study, just 1 hour with a nurse who was educating the patient in detail about the strategy for just the things you mentioned: when to take medications, when to follow up, what to do what symptoms should trigger concern or a call to the clinician, and what to do when those symptoms happen, that strategy for self-monitoring. Relative to a strategy where none of that education was provided, was associated with a marked reduction in rates of readmission over the ensuing 30 and 60 days. So I think simple interventions that we may take for granted to help patients understand their disease, the rationale for medications, and the strategy for longitudinal maintenance, I think, is a critical piece of keeping patients well with this. And that's a big part, I guess, of what we call heart failure disease management. One of the things that I think also comes up in this context is, how do you think that we optimally should set up heart failure management? Because a lot of people care for heart failure, right? There are some patients followed in primary practices, some followed by cardiologists, some followed by specialists, a lot followed by teams of nurses. So what does your strategy look like at your institution?
Well, how it works at my institution and how it perhaps should work are not necessarily the same, but in my view, the key issue is that the people who follow the patients with heart failure have to have some experience in taking care of patients with heart failure. That can be acquired, but that's critically important. It's not only didactic knowledge, but experiencing the patients, so that whether it be a nurse practitioner or an internist or a hospitalist or a cardiologist, the person is familiar with heart failure and spends a great deal of his or her time, great proportion of his or her time, focusing on that problem. It's very difficult to be a wide-ranging generalist in the current era.
Yeah, I'd agree with that. I think, especially because some of these patients, particularly the elderly populations who have a lot of ancillary needs that really require time and very focused interventions, and sometimes without a team of physicians, nurses, and mid-level providers who can provide an integrated, multidisciplinary frame for heart failure disease management, it becomes hard to keep patients well. And one person doing it alone sometimes isn't enough. Just because it comes up in discussion of these sorts of cases all the time, it might be worth mentioning a little bit about the role of natriuretic peptides. And do you measure them in hospital at all? And how do you use them in the outpatient setting?
Very interesting, and I suppose appropriately called a controversial issue. The best data of which I'm aware indicate that natriuretic peptide measurement is useful in confirming a diagnosis of heart failure. Whether natriuretic peptides can be used to titrate therapy is another issue. And as you know, there's a large randomized NIH-funded trial looking at the strategy of managing drug therapy based on periodic BNP measurement and a control group where BNP isn't routinely measured. I think we have to wait for the results of that trial to be made public to know which strategy is best, and then we'll have to look at the way the trial was done. As the chairman of the Data and Safety Monitoring Committee for that trial, I really can't talk about it, but there are single center studies that go in both directions. So I think we have a real issue here. Personally, I think that natriuretic peptide measurement is very useful in situations where the diagnosis of heart failure is unclear. It also, I think that it's useful in terms of gauging perhaps the severity of volume overload that one is dealing with. But using the natriuretic peptide to titrate therapy, I think we need more information before we can say that's the right thing to do.
And I guess a final topic to think about around this is that we've found that, and this may not be a great example, this is her second admission for heart failure. She does have a background history of breast cancer, but it always raises the question for me about whether this is the second and the harbinger of more hospitalizations to come. And we do know that patients who leave the hospital, or at 1 in 5 of them is dead at a year, and the more hospitalizations you have, the more likely that outcome is to happen. So I wonder if you might comment a little bit about your approach to thinking about palliative options in this population, or and when do you start to integrate palliative care considerations in heart failure patients?
I think that's a good question. I would add one aspect to that discussion. It's absolutely true, of course, that hospitalizations beget hospitalizations and hospitalizations beget death. And when a patient has heart failure, since there's a 50% mortality risk within 5 years, no matter what else you know about the patient, it may be appropriate to begin to discuss with the patient's family, the likely natural history and what their expectations are. And depending upon what you learn, it may be appropriate to get palliative care people involved fairly early. But the other issue that I was going to raise when you mentioned this was, at what point do we consider LVAD or transplant? Whether we want to consider it is fine, whether the patient wants to consider it as something else, and whether transplant particularly is available given the paucity of donors, is another concern, whereas LVADs are more readily available, costly but more readily available. What do you think about LVADs in a situation like this?
So I think absolutely. I think that particularly as the technology has advanced and the complexity of implantation has gotten a little bit less and the outcomes have improved, I think it becomes a really viable option for many patients approaching the end stage of heart failure. And you're absolutely right to draw that at the moment we're considering refractory disease, we should be thinking about all of these options. Transplant is the option for the minority, and so I think the opportunity to have LVAD as lifetime therapy or as a prolonged bridge until transplant is a critically important gap measure. And I think that it's increasingly becoming a reasonable way for patients to live with good quality of life outside the hospital. I think it's not every patient that will live life on an LVAD, and I think it's very hard for some to envision life on a pump with all that it entails. But I think we owe it to patients as they show signs of approaching that stage D transition to at least begin to introduce the concepts of what options are available and help them through the decision making around whether this might be a reasonable therapy for them. But I think for the right patient, LVAD therapy can be life transforming and can really improve the quality of life and hopefully the quantity of life for many.